Okay, so my first protocol is coronary ischemic chest pain. First thing we're going to want to do is get a general impression of our patient. So that's going to be just a general kind of through the door, first thing impression. Ready? Want to get some ABCs, from afar. Is my patient breathing? Does my patient have good airway? Are they circulating blood? How does their skin signs look? Are they pale, cool, diaphoretic? Do they have good normal skin? Do they look hot? Are they sweating? Things like that. The next thing we're going to do is we're going to want to get just a brief history. We can use the OPQRST mnemonic for that. Get an onset, provocation, quality of the pain, severity, radiation time, all that kind of stuff. Also, we're going to want to get allergies right off the bat, just because we are going to give medications with this protocol. Some allergies, also some past medical history. If they have previous chest pain, previous heart issues, that can kind of also maybe help point us in the right direction or point us down that path. Let's see, first thing we're going to want to do is get some vitals on the patient. If we determine that we're going to be doing chest pain protocol, we're going to want to start them on some low flow oxygen. Like I said, vitals, put them on the cardiac monitor, and then we're going to want to quickly get some aspirin on board if they don't have allergies to it. It's going to be 162 milligrams, which is 2 81 milligram chewable aspirins. Make sure they're chewable. The non-coated chewable aspirin is the preferred route, and that is an anti. Well, I think it's anti-platelet inhibitor is what they call it. So any platelet effect that the blood might have, that's going to kind of diminish it, which is going to make that blood more, I think viscosity is going to be the word maybe we're looking forward to, help it flow through the body easier. Once we get those vital signs back, hopefully they're not hypotensive, hopefully the blood pressure is healthy, good above 100. That way we can give some nitro on board, some nitroglycerin. That dose for that is 0.4 milligrams, which is 1 sublingual nitro tab. Also, shortly after that, we're going to want to start an IV with, just so we have the ability to start a bag of fluids in case we accidentally tank their blood pressure with the nitroglycerin. Nitro is a vasodilator, so it affects the blood pressure greatly. After we start that first sublingual nitro dose, we're also going to want to put 1 inch of nitro paste on them to maintain a therapeutic effect. Keeping in mind, though, blood pressure, making sure they don't go hypotensive, and if they do, wipe that paste off of there. We're also going to do a 12-lead ECG. Going to want to look, obviously, for a STEMI. So, STEMI or not, either way, we're going to be treating for chest pain. If they have a STEMI, we're going to want to do a stat transport, obviously. Let's see if they're having a STEMI, you can give them some fentanyl to relieve that pain as well, which is going to be 25 to 100 mics, about 1 mic per kilogram. So, and that also is going to affect blood pressure, so we're going to want to make sure they are not hypotensive for that either. Make sure the blood pressure is above 100. For the nitros, we can continue administering nitroglycerin until a max dose of 3 tabs or 0.12 milligrams. We're going to want to make sure before every administration that we have a blood pressure above 100, and preferably a good amount above 100, because we don't want to tank their blood pressure. Some special considerations would be amiodarone for this protocol if they have like Venza VTAC or something like that, but we're gonna have to contact base hospital prior to administration of amiodarone. The other thing is midazolam, which would be a 4 milligram slow IV push. We're gonna want to give that if chest pain is suspected through a sympathomimetic use. 4 milligrams can be repeated 1 time, but things like that are things that maybe you could check in with a base hospital about, just to for sure be comfortable and confident in the way you're treating your patient. All right, VTAC with pulses. Step one, the ABCs of patient, determine all that airway, breathing, circulation. Is my patient conscious? Kind of get a baseline through the door, lick on them. Next thing you're going to do is going to give them oxygen. Going to start high flow, 15 liters, unless they have COPD. It's a contraindication for that. So COPD patients, you're going to start at 2 liters per minute nasal cannula, titrate up to either the desired SpO2, desired patient effect, without going too high. You also want to get an IV on these patients. You want to get an LR at TKO started for them. Then you're going to want to determine, are they stable or unstable VTAC? So is their rhythm over 150 beats per minute? Are they having CHAPS? So are they having chest pain, hypertension, altered mental status, shortness of breath? And at what at what level are they having these? So are they like severe chest pain or severe hypertension, or is it just my chest hurts a little bit, or just how severe are they on those symptoms? So for severe patients, the STAT patients, they're having the VTAC, so they have rate over 150. They're having severe symptoms associated with CHAPS. You're going to want to first consider midazolam and fentanyl before you cardiovert them, if time allows. So the dosages for midazolam is going to be 4 milligrams, but if they're over 200 pounds, 8 milligrams. It can be repeated once for the 4 milligrams, so I believe it's a max dose of 8 milligrams. Fentanyl is 25 to 100 mics, typically 1 mic per kilogram for the patient. I believe that can be repeated once as well. If you have time to do that, great. If not, you're going to go straight into cardioversion. So first, you're going to want to sync your monitor. The first dose is going to be 100 joules for a monophasic monitor. So you're going to synchronize, cardiovert. I'm clear, you're clear, we're all clear. Cardiovert, reassess your patient. Are they still in VTAC? If that converted them, great. Give them 150 milligrams of amiodarone to hopefully prevent a recurrent episode of the VTAC with pulses. If not, you're going to bump it up 200 joules at this point. Sync, cardiovert, reassess. If that doesn't work, 360 joules, sync, cardiovert, reassess. Like I said, after you have successful cardioversion, 150 milligrams of amiodarone to hopefully prevent recurrent VTAC. Then if you do get recurrent VTAC, cardiovert again, but start at the dose that converted them the last time. So you don't put them through all the pain of bumping them up until you finally get the effect. Just go straight to, just hit them hard straight with what worked last time. Some for stable patients, you just want to give them, oxygen transport, monitor them. But for those kind of borderline patients, you're going to want to give them amiodarone first before you cardiovert them. Give them the 150 milligram push over 10 minutes, and then you could rebolus them in 30 minutes with another 150 push over 10 minutes if they don't convert. So if you have like a long transport or something, you give them the 150 milligrams of amiodarone, still in the same rhythm, maybe coming from where I live in Oakhurst, and then get to like Madera or, Avenue 15 or something. They're still in that VTAC, still stable. Give them another 150 over 10 minutes. Maybe by the time you get to St. Agnes, they'll be good to go. See, some special considerations are suspected hyperkalemia, which could be with like a tricyclic antidepressant overdose, patients with renal failure, fistulas, shunts, for those unconscious patients, so that, dialysis patients basically. You're going to want to give them calcium and also consider sodium bicarb. Okay, my last protocol is PEA. Step 1, ABCs. Does the patient have a pulse? Is the patient breathing? They shouldn't be because they're in PEA. Cool. Start CPR. Have your partner start CPR. Make sure they're doing good, adequate CPR. Then next thing you want to do is work on, airway. Hopefully you got fire there, so you can say, hey, put an OPA, MPA, whatever. Make sure they're having good complacency with the bag in the BLS airway. Next thing you want to do is start going to get vascular access, so IV preferably, but if not, IO. After 2 minutes of CPR, you're going to want to give 1 milligram with 1 to 10,000 epi, either IO or IV. Continue that CPR for 2 rounds. Just make sure that rhythm remains in PEA. If the PEA is less than 20, then continue working. Well, either way, continue working. Give another dose of epi, 1 milligram, 1 to 10,000. At 2 rounds after the first one, so they say between 3 and 5 minutes. That should be about 4 minutes afterwards. Give them that second dose. Continue doing CPR, good CPR for 2 more minutes. If they're still in that PEA with a low rate, less than 20, determine time of death, and on to the next one. Also wanted to add, if the PEA is above 20 or the rhythms are going between PEA and something else, like a mega code situation, you're going to want to continue working that cardiac arrest. If their PEA is above 20, say they got like PEA of, 40, I don't know, whatever. Continue working them, continue doing CPR, continue giving the epi, your rounds of ALS medications. You can contact base hospital for termination of code or transport. So other special considerations when you have a patient in PEA is your H's and T's. What was the cause of death? Are they hyperkalemic? So in that case, just like the VTAC with pulses, you can give calcium, and then you can also consider sodium bicarb. So like antidepressant overdose, maybe a patient on dialysis, you can give them those additional drugs as well. And if you suspect some hypovolemia, instead of keeping that LR at TKO, maybe you could run it wide open to kind of try to combat some of that fluid loss in the tank, if you will. That's it.